In this episode of the TPG Difference, we are going to be discussing the pros and cons of direct primary care, or DPC. Instead of fighting insurance bureaucracy, patients, or sometimes their employers, pay a simple, flat monthly or annual subscription fee for routine and preventive care. No copays, no claims, no 10-minute flyby appointments, just access, time, and a real relationship with a clinician. The debate starts now. Welcome to the TPG Difference. Today we're talking about direct primary care. Across the nation, establishing a new relationship with a primary care physician is becoming a little bit of a minor miracle. And we recently read in a Forbes report that 35% of Gen Z trusts TikTok more than they trust actual doctors. When influencers beat out MDs, you know our system is in trouble. But a new model is emerging, and that's what we're here to talk about today, and that's direct primary care. We'll call it DPC for short. So here with me to debate the pros and cons of direct primary care is my panel, starting here with Zach Fritz, Case Escher, Chad Kemmis, and the stash. Thanks for bringing it back for November. And Lily Beck. Welcome, Lily. This is your first time on the TPG Difference, and we're really glad to have you.
Thank you for having me.
Yes, this is a fun format. It's a great way where we can get a lot of dialogue and some pros and cons on the table for our clients about these new evolving trends. So let's get into direct primary care with issue one. Issue one is all about access. So here's the question. Does direct primary care meaningfully solve America's access crisis, or does it simply shift a limited supply of clinicians into a smaller subscription-based panel? You're our newest panel member, Lily, so what do you think about starting with you? What do you think?
Well, this is very timely. I just went in to set up my, my primary care, annual physical, and it was a 4-month wait. I've seen that those statistics are a little bit different depending on kind of where you pull the numbers from, but I do think that this is a great opportunity to be able to open up access, especially when we think about that primary care relationship being kind of the driving force for a lot of your care. That can be a very important relationship to be able to, have trust in and make sure that the rest of your care is going as you would like it to.
It is definitely ideal to have a relationship with a primary care physician who knows all about your health history. So what about access from anybody else? What are you guys seeing with your clients and in the market or in your own families?
Access is rough. Just like Lily's story, I've got 3 Gen Z kids, and they're relegated to urgent care when they have an issue. So they can't get in. In fact, my youngest luckily has someone who's a receptionist and gave her the sneak text that we have a new physician. They're open for patients now. And so she got something scheduled. But if it wasn't for that, she probably would have been just waiting a long time as well. So access is definitely an issue. I'm hearing that across the board, clients, family, and whatnot.
Well, and I think we see that day in and day out as we're reviewing claims experience and reports with executive leaders of companies. I mean, one consistent theme that comes up in a lot of meetings, strategy and renewal, is how can we limit emergency room usage unnecessarily, right? And that trend just doesn't seem to be abating. And so the lack of family physicians and the access to get into primary care only makes that worse, and it just exacerbates the whole system that we operate in terms of cost increases. So I think a lot of physicians and folks in the industry that I follow say that if we can help solve that front end access issue, that opens up a lot more flexibility downstream for employers controlling their costs, employees, members getting access to better care at the right time in the right setting versus just going to emergency rooms when it gets too bad to deal with.
Well, we definitely have a numbers problem, right? That just the number of physicians who are going into family practice, right, is not enough to serve the needs of the American public. And so what happens if we suck all of the family practice providers into these direct primary care models? who is left to serve the people who aren't in a DPC world?
Yeah, well, I was actually going to say exactly what you just said, Sarah. I don't know the stats, but I know that going into primary care isn't exactly where people are flooding. The money's not the same as obviously if you go into a specialty. And I think that's where we have to sort of rethink who you need to see and who you need to talk to, right? I think obviously having a primary care relationship's super important, but we also know that a bunch of the things that you get done when you go see your primary care provider is done by a nurse practitioner or a medical assistant. And so I think just sort of thinking more about, access in terms of where is it going to come from. It's a serious problem, but I think there's a reason we're talking about this today, right? Because I think there's other ways to get a lot of things taken care of, but still have that relationship sitting there, because you've got a price issue, an access issue, and like you said, the supply demand is real.
Which is a bummer because it seems like most people that would go into family practice, general family medicine, they truly want to be there to help and establish relationships and be that go-to person, but they're strapped in our current fee-for-service model and just their own overhead and trying to get as many patients in as possible to remain financially viable. That's where I think we're going to spend a little bit of time today talking about some of the alternatives that might alleviate that, hopefully, to maybe allow those folks to see more people more intentionally rather than you going in. And I think we all feel this, and it's not a reflection of our provider, but as you check in, you fill out your form, they take your measurements, you sit in there by yourself for a couple minutes, the doctor comes in, sees you, leaves, and it's hard to feel like you're really establishing a relationship with a primary care provider because they're stretched so thin right now.
Yeah.
And this is slightly pivoting, so we don't have to tangent too much, but I'm curious, Case, because you work with, and we all work with different clinics, health systems, just how the primary care is being viewed within the systems itself, in terms of bringing those on. And then, we've talked a little bit about how it's can be a bit of a loss leader. And so there's a lot of things, I think, pushing the walls in around, more primary care providers. So.
Yeah, there's been consolidation in the primary care space. When I was younger, there were more primary care, more family physicians around, and since the ACA and beyond, we had meaningful use from EMR mandates and everything past that. It became more untenable for individual or even small medical groups to survive on their own with the investments they had to make, and so larger health systems have slowly started, acquiring primary care physicians, and really, their interest in doing that is vertical integration. And when I say vertical integration, I mean, basically, if a health system has the primary care physicians, and the primary care physicians can then create referrals into other specialists that are within the health system and facilities. So economically, it makes sense from a health system perspective, but the fallout of that is really a scarcity that we're seeing in terms of supply. And you see more patient loads on fewer practitioners.
How much does AI help that, potentially?
There are any number of practices I'm aware of that are leaning into AI to help with the efficiencies as far as patient care, documenting, noting, right? There was a day when they hired scribes, and the scribe was to take the notes from and then just put them in the EMR. Right. So AI is definitely going to create efficiencies. Personally, we talk about TikTok. I've never gone to TikTok for any sort of second opinion. But I have.
What about ChatGPT?
I have gone to ChatGPT, and ChatGPT does an exceptional job. And I'm not trying to create medical advice here, but
we need a new disclaimer for the TPG difference.
But I will say this:
it's the #1 most researched thing on.
I know.
ChatGPT.
But rightly so. But it's just last point I'll make before I yield the floor here, is that one of the problems we've had for years working with employer groups is health literacy. Right, and you've got a bunch of people. That's why certain professions they utilize more than others, like nurses, doctors. They utilize more healthcare in an employer-sponsored plan than, say, car mechanics or other industries, because they're health literate. They know what to ask, know how to ask it, and so on. And so if ChatGPT does nothing else, it creates a smooth and easy path for greater health literacy, and I think that's where I see the biggest benefit.
I think.
Oh, go ahead, Lily.
Oh, I just wanted to build on that whole TikTok kind of reference and with regard to access, because I think health literacy is a great component of it, but also the fact that it's there. You can just pick up your phone and you can search whatever you want to on TikTok. And then if you like that content, it's kind of like picking your primary care provider or subscribing to that content because you believe in the philosophy that that person is pushing out there. It's easy to get, it's free, first of all, that's huge. And also, I mean, it's accessible not only from a technology standpoint, but also from a literacy standpoint of they're speaking the same words that you and I are speaking. So it's easy to be able to understand what they're trying to say. So I know a lot of my friends will bring up things that they have found on TikTok that they now want to go to their doctor to get the tests run because they feel like they're able to spend more time with that TikTok person than they are with their actual doctor because they have the time for it.
Well, before we get off this access issue, I want to just press in on the cost, right? Meaning, if people are not being able to access, a primary care physician, and they end up in immediate care, in urgent care, in, God forbid, the emergency room for things that don't warrant an emergency room visit. Talk to me a little bit about the cost of that to an employer-sponsored health plan. And is that the reason that employers are considering more DPC strategies in their employee benefit programs?
I think it's a little bit of both. I mean, I do think that that's an easy thing to attribute finances to. You see ER visits. I mean, just every single year, that seems to be a topic that you're trying to bring down ER visits. And that is exemplified in shows that are on TV right now. So like my wife was watching The Pit, which is a cool show like in the midst of an emergency room. But you just look outside when they step out of the providing care setting and just in the waiting room, and you have tens and 20s, 100 people just waiting there to be seen. Like that is not an efficient way to seek care. The other part, I think, is as employers continue to look at ways to differentiate themselves in their total rewards package, that's a creative way to go about that. And we'll talk a little bit more, I think, about different mediums in which primary care gets delivered, but it's not feasible for most companies to go build out an on-site clinic and hire a physician. Like that seems like a totally novel concept, but actually bringing direct primary care, when we hear this during open enrollment meetings from employees of I can't get in to see anyone, that is a different way to think about how do we bring a better benefit to people that may impact ROI down the future or may just be an ROI on employee engagement.
Well, and I think it's an interesting one because I think that our clients, our employers understand there's an issue. I think it is hard unless you're just a massive employer with really, really credible data to be able to provide kind of the link to one thing creates another. So, I think about ER, yeah, that's a big problem, but that's not necessarily where you have the massive large claim. It's, what are they in for? And then what's going to happen after that, right? I think about someone who's going to basically be like 4 months to get a primary care. I'm just going to skip it, right? And probably at that point, they're generally healthy and aren't having an immediate need. And then what does that immediate need turn into? And then I always think about, and we talk about this with our employers as well, it's like when you're going to make an investment into something, you have to either do it because you just philosophically believe in it, or you think it's going to yield savings. And then when you have turnover, when you have people coming and going, the investment into well-being and the investment into DPC, you may not see the full ROI for that one individual if they don't stay with you, right? And so there's just a lot of factors involved, right?
Well, let's dig into ROI as our second issue. So for employers adopting direct primary care, there's a cost to it, right? So we talk to our employers a lot about, about the components of their plans. Everything has a price tag to it. So if you're going to add this layer of direct primary care, is the return on that investment driven by real reductions in downstream claims, or is the savings narrative overstated and dependent on ideal conditions? So, Case, let's start with you.
Wow. The answer is
Answer is a single
What
answer.
is ROI?
It's really dependent on ideal conditions, and we've touched on it a little bit. Chad brought it up. Zach, in his own very reductionist way, explained correlation versus causation. And when it comes to vendors who pitch direct primary care, and we talked about this, there's three general modes that it comes in. When I first, in my career here, started vetting ROI for direct primary care, it was an on-site clinic. So for an on-site clinic, you have to have an employer with a bunch of employees in one place. You have to have a good number of employees in one place and be willing to make a significant investment in staffing that clinic.
And brick and mortar. It is a big investment, yeah.
It is. And so to perform that analysis, what I did is I looked at all the utilization that was happening, the episodes in the primary care clinic, and I priced them outside of the clinic in the community providers to see what would these encounters have cost if they occurred outside the clinic. Then I factored in the fixed cost, and really what I got down to is like all statistical analysis, I could torture the data to tell me anything I wanted it to tell me, but I don't. I only use my powers for good, not evil. So when it was all said and done, it seemed to be a draw, but that draw depended on a series of assumptions you have to make. Yeah. And one of the assumptions that was important was the fact that the clinic is there doesn't create its own demand. And my assertion was, I believe some of these encounters probably wouldn't have happened anywhere if the access wasn't there and the ease wasn't there. And the flip side of that is the employer says, well, yeah, but that employee was at their desk now. They didn't have to take 2 hours, so I got a productivity gain. So there's all these different layers to this onion as far as how ROI goes. And none of them are bad to consider, but at the end of the day, there's a lot of factors that go into direct primary care from an employer's perspective. And what I will say is philosophy is a big component of that. There's one model that I would say you are most likely to get ROI on, and that's virtual direct primary care, which we'll discuss. Any other model, I think it's going to depend.
So let's go through the other models. So you described onsite, which is basically single employer owns their own clinic, right? And it's generally closed to any other individuals in the community. You have to be an employee of that group in order to access the clinic.
So, or dependent maybe, yeah.
Nearsite, talk about nearsite.
Yeah. Nearsite are brick and mortar providers in the community who offer a per employee per month fee for, it's almost like front of the line access. So they don't exclusively do direct primary care, but they offer an additional subscription-based service to employers in the area. The other thing I was going to bring up is that primary care, by most estimates, and I've actually confirmed this, is between 7 to 8% of total cost of a year for an employer. And so that's a really good figure to hang on to, because if you've got a $10 million spend, that implies that 70,000 of that 10 million, I'm sorry, 700,000.
I was like, okay, yeah. Okay.
700,000.
You're gonna have your math card revoked.
700,000 of that annual spend is going to primary care, right? And so when you look at, well, if we're going to put in a direct primary care offer, is it going to completely replace that 700,000? Is it going to replace some of it? And those are the questions that need to be asked. So by and large, what's killing a health plan, what's killing employers, what's driving 25 to 30% increases isn't primary care, right? It's the sick few that are driving those costs. So I forget why I brought that up, other than you asked about other modalities. Yeah, nearsite models. And the nearsite models tend to be pricier than the virtual direct primary care, but less costly than the on-site brick and mortar, building out your own.
Well, and then there's also the concierge direct primary care, which is an old model that is not only available to employers, but on an individual subscription model. Yeah. So does anybody want to describe an example of that, just to get all the models out there?
Yeah, I mean, I think I think those are more like you said, concierge, almost like I feel like more of an executive perk kind of concept. It's not something, because generally a lot of those providers are also billing insurance. So they're kind of double collecting. And like you said, you're just paying that subscription to get, jump the line, or maybe they're not taking as many patients so they can spend more time with you, things like that. I think I've seen that it's stuck around, but I don't think it's really taken off. And I think that's because it's just for a small group of people that can afford it, right? And I think employers, are probably hesitant for that model because they're not going to tell, their executive team or certain individuals like, well, now we have this individual you should go see. They have their own relationships, right? So I think it's there, but I don't think it's really sort of in the conversation really that we're having, because it's just such a small fraction of the people that are really either able to afford it or being offered it.
Well, and as we talk about ROI, all of those models, right? That's a large spectrum of models that are available for employers and individuals to choose from, but that's a wide spectrum of costs too. So you could be investing north of $500,000 a year in an on-site clinic, or you can pay $12 per employee per month on virtual care, right? And so obviously that investment drives ROI. So Chad, how do you talk to your employers about ROI when they're even considering direct primary care as a solution or a part of their benefits puzzle?
Well, we're still in the early days of having viable options for a large swath of employers to actually implement. And so we won't disclose this today, but we're quite excited about our own rollout of virtual direct primary care for TPG employees in our own plan. And that'll be coming to a,
Theater near you.
Theater near you soon. But I do think it's more of a philosophical discussion around what are we trying to deliver to our employees. I think a common question that I get in the conversations I brought up is, how is this any different than like an MD Live or a teledoc or the embedded telehealth option within our medical plan? That's people's number one thing. How is this any different than that? And that's what I think takes further dialogue and conversation around how is a virtual direct primary care solution different in its structural components to what those other services offer. And not that those are not relevant, but I think everyone around this table probably expects that most clients that we have, when we talk about utilization of those, it's single digits, like low single digits maybe, right? We have large employers we work with that their utilization of teledoc is 1 to 5%. And it's not a reflection, again, of teledoc and their service. It's just, it kind of gets lost in the shuffle. And so I think there's some intentionality that needs to happen around the rollout, the communication of it. But I think the feature of having a clinician or a team dedicated to an employer on that subscription model who gets to know the ethos of a company, they see people multiple times. I'm not just calling for my daughter and getting whoever across the country randomly picked up the phone who's moonlighting, for one of these telehealth vendors. They are dedicated to a text-based care product like we're discussing, and they get to know myself, my family, TPG. I think that there's some value in that comparatively to other options on the market right now.
I also want to just say one thing real quick. Sorry, Lily. Then I think we have to also remember that a lot of what we're talking about, while you might normally go through your primary care office, it's not primary care traditional visits that we're talking about. It's the random thing that happens on a Saturday morning where, the system would suggest you need to go see somebody.
Right.
And
I almost cut my finger off this weekend.
There you go. See, Chad's almost lost his finger. But that doesn't have
Saved
to.
by a Band-Aid.
Exactly. The Band-Aid.
6 months until he's gonna get that looked at.
Direct primary care, Band-Aids. But avoiding that, whether it's an urgent care or whether it's a forced virtual call with the provider to check a box for something that we all know, like we generally know what we need to do, which is likely just get a prescription written and be on our way, So I think about DPC a little bit different, not differently, but I think we have to open it up to more than just, either replacing or augmenting traditional primary care, because there's so much application for the right type of DPC model beyond just what you would maybe get done with your traditional primary care. I had to get a prescription a few months ago, and it was just painful. And I spent 3 minutes on a virtual call with a nurse practitioner. It wasn't my doctor, but I had to see my doctor's office, right? And then I got the $250 claim bill. It's like, I knew exactly what I needed. And had I had the right DPC model, I could have gotten that done right away and taken care of.
Well, I think another differentiation for me on, nurse advice line versus direct primary care is direct primary care can order labs, right? And so if you want to get your preventive screening done, you can text and they can order all the labs, and you don't have to wait 90 days to get in for your screenings. And for people who have really busy lives, and sometimes just making that phone call and hearing that it's a 90-day wait is the thing that stops the activity, the scheduling, and then it doesn't happen.
Yeah, that's why I like the virtual direct primary care. I mean, they're not all created equal, and we'll dig in that probably in another session as far as the ones we like. But if I were to think about a steel cage death match, and in that steel cage death match, you have on-site clinic with all of its glory, its expense, but it's there, it's always available to your employees, and you have virtual direct primary care, kind of like we're talking about, text-based. And we were to evaluate the ROI and efficacy and the benefit to the employer and employees on one metric, and one metric only, and that metric is how much time did they take off work? Or how much time did they spend in order to get that issue taken care of? Virtual direct primary wins every single time in that match. I'll bet him on salary on it.
Even
Polymarket, can you spin it up for me?
Yeah.
Okay, that leads us to issue 3 though, because it's not all about the productivity of an employee in their seat at work.
It's not, but
I appreciate you wanting us to only take 30 seconds off to take care of ourselves.
We're just a number to you,
Do
Kate.
you remember our first session here?
Yes. Oh, we're going back to ICRAs. No.
I'm the CFO here.
Oh yeah, I
want-
forgot.
I know you may be in a
I want
different chair.
people.
but-
Yeah,
Yes.
I'm just kidding.
So real quick, just on the ROI topic before we move on.
Yeah.
I think there's another element to this that we have to keep in mind of direct primary care only has so much care that it can deliver. There's imaging, there's labs to your point, there's maybe a specialist visit that's needed. So when we're talking about the referral basis that comes out of direct primary care, I think one of the things that's really important to keep in mind or know about whatever vendor you partner with is how are they making that selection to whoever they make that referral to? Because, talking about healthcare in general, there are high efficiency, low return, lower cost providers that are out there. In case you referenced kind of that vertical model of, the referral source for primary care. So I believe there is an ROI element to that as well that goes beyond the direct primary care. If you're making a, referral to a special outpatient imaging center rather than a hospital-based setting for your MRI or your X-ray, that's going to be cheaper on a claim spend to the health plan than it would be, if somebody was making that referral from their vertical.
Excellent point. So being able to speak into that as an employer is useful in the DPC model.
Well, let's shift to issue 3, which is quality. Because yes, convenience is important, cost is important, but quality is also should be ranked pretty high on our list of things we care about. So the question is, does DPC improve the quality of care through longer visits and stronger relationships, or is there still insufficient evidence that outcomes truly surpass the traditional primary care model? Zach, let's start with you.
Well, I think, again, it sort of depends. Not trying to be cagey here. Or going
to the death
or go
match.
into a steel cage match. But I do think there's an opportunity for DPC done the right way to actually enhance quality. I think the ability to have someone that you're seeing that, like, even if you're doing it virtually, that someone you're seeing, the same clinician that's starting to get to know you a little bit, that's doing follow-up work. And there's DPC models like that. The one we're rolling out at TPG has that component to it, where you're not just, hoping this time you get somebody who's really good and the next time you use them, it's somebody different and they're like starting from scratch again, right? So I think when done right, it can be, and that would be similar to an onsite or nearsite model where you're going to see the same people. And so I think from those perspectives, the quality is going to increase. And I still go back to, for me, a lot of what we're using this for is for things that we could go look up on ChatGPT or TikTok ourselves. So we just want to be able to get to somebody that's competent, that we trust, and that doesn't always have to be a doctor. It can be a doctor, it can be an MP, it can be a PA. Like, as long as we have a person that feels like they understand us and our health, I think that we're, generally speaking, we're okay with that, right? Now, maybe others aren't, but they're probably not the ones that are going to adopt this, no matter how much we push. So,
Excellent point. DPC is really for the bottom 80% of claimants in a population, right?
that's right.
The 80-20 rule is alive and well in healthcare. 80% of the spend is driven by 20% of the claimants, the sick, the chronically ill. But everybody else is stuck in this, takes 90 days, 4 months to get a new patient appointment. In the meantime, you're relegated to urgent care or ER. So to Zach's point, DPC is a benefit and something for the well, and we'll call it the walking wounded, like your finger. Yeah. So people who generally don't use the system, but are dinged every time they do. Right. And that's another reason why I think it framed the right way and rolled out the right way, it can be a huge benefit to an employee population.
But it's definitely on the convenience side of things. I think it would be hard for us to argue that that model is generally a better clinical outcome than having a face-to-face visit with a primary care doc and establishing that relationship. But just what we were talking about earlier, the feasibility of that is hard for a lot of people unless you are quite successful financially and you join a concierge type clinic and they can see you and treat you at any point, or they come to your house, what have you. The vast majority of people, that's not a reality for. And so how can we deliver something that is good to better than what they have today to as many folks as possible, especially as more and more people are not in an office setting, or they're not in an urban setting, and there's more spread out amongst rural and work from home. It's how can we still get them access to care that is high quality when that may be out of reach for them otherwise.
Well, and the statistics are 6 in 10 Americans live with some sort of chronic condition, and 4 in 10 are juggling multiple conditions. And so to your point, Chad, yes, a traditional one-to-one clinician relationship is ideal for somebody who is dealing with a chronic condition. But to have nothing, you can't treat really high blood pressure in an emergency room setting, right? They aren't going to track you. They aren't going to have you coming in for med checks. Like, you really do need some sort of primary care physician. So I like your, okay, if we're going to tier them, yes, we would all love to have in-person personal relationships with family practice doctors like we used to.
Home calls.
Yes.
Yeah. They come to your house and see you.
Yeah, that would be awesome.
That'd be ideal.
I know.
Well, that's the robots will start doing that in the future.
Yeah.
There was a time.
But that time doesn't exist anymore. Right? And so given our current reality, direct primary care is a really useful model I used to have no conditions, and then I turned 50 and it was like, oh my gosh. And so I'm really grateful I finally got a primary care physician. And as a woman who's had 3 kids, my primary care physician was my OBGYN for 20 years. And that was fine until age caught up to me and I had other things that I needed to deal with. And it took forever to establish a relationship. And I'm so glad I did. But had I not, I'm in the business. I know how important it is. We know how to access the system. Most people don't. And even my kids give up, right? And so my kids don't have primary care physicians. They've aged out of their pediatrician and they're in this gap that so many 20-somethings are in. And they get their care through Zoom care and other models, because every time they try and establish a relationship, they give up when they hear it's 4 months. Well, that's basically never for
I know.
them.
Yeah. Well, it could be, it's eternity, right? Yeah.
Eternity. Right. And I don't think they're unusual, right? I don't know that, I haven't asked them about if they're getting, advice from TikTok. We'll see. I'm gonna ask.
You gotta be careful with the social media advice. I'm just saying. Like,
No, absolutely. Yes. That's a big disclaimer.
That'll be a serious
Did you
debate for
just
another
now
day.
come to that?
there's a lot of people out there pitching a lot of interesting things, and it'd be good to just get a second opinion with ChatGPT or a real person before you go and start.
Sounds like you need to spend less time on TikTok, Case.
I also think your chat GPT should probably also be second opinion by a person, but that's just my opinion.
I have a strategy for that. I put one AI model against another against a third, and I basically, get them to either agree or I just abandon it.
Throw them in a cage together.
Exactly.
Yes.
There you go.
Okay.
Someday.
All right.
Next up
All
on the
right.
TPG difference,
Yes.
AI steel cage deathmatch.
So
that sounds good.
speaking of putting two things against each other, I have a question, and this is with or without direct primary care. How many of your employers, when you went through January 1, 26, renewal season, how many of your employers are talking about direct primary care strategies? Or with the One Big Beautiful Bill, I think this resurfaced this topic because it can now be paired with health savings account and high deductible health plans, right? And so I feel like this whole DPC model got a resurgence of energy because of that bill change. So tell me a little bit about the attitudes around DPC with employers and the interest level.
Many of them, I'm bringing it up to them. They're not asking me about it.
No,
And what problem are
agree.
you trying to solve when you bring it up?
I'm trying to solve the access issue. I bring it up as there's a lot of people on your plan that pay in, make contributions, and get not much out of it. And wouldn't it be nice if you could bring them a benefit that they can say, well, thank you.
The 80%.
This makes my life easier.
Yeah. Well, there's not a lot of good news right now, right? I mean, this renewal season was the worst that most of us have seen. And so I think a lot of people are just feeling overwhelmed. And it does take the conversation being nuanced in the right way. What are the values of this? Because it does feel, I think for a lot of people, their gut reaction is we can't absorb more expense. And so it's just talking through and understanding the culture of the employer, what they're trying to solve for in their total rewards program, where DPC hopefully fits in. But it should fit in for a lot of employers.
The right model.
Yeah.
I would say 100% agree. I had none of my clients actually ask me about DPC. So it was very much a proactive, discussion around this is something that you should be thinking about, the virtual model, a lot of white collar that I represent. And I had it was a 3-prong piece for me. It was access, it was ROI, because this particular option is a fairly low cost, comprehensive way to kind of approach it that I do believe will drive ROI. But it was also an additional benefit. It was a win in the ugly renewal season when so many employers are having to do a little bit to scale back or add costs to the employee. Like where can you have a win that's going to be an actual tangible win that everyone can feel? And I think if done right, it can be a minor retention perk too. And so I thought about it. I was thinking about it from 3 different distinct buckets. And again, if told right, I think there's a lot of receptivity to it.
Completely agree. I think the access issue is the biggest conversation, especially also to add to what you all have said, provider negotiations. As we're seeing more and more bounce in and out of network with who you may have access to, being able to have an option where they know what your network is, they know where they can refer people to, but you just have the ability to pick up the phone or reach out to them. However, has been a big win.
That's great. Well, I know there's a lot of energy here at the Partners Group for the direct primary care layer that we've added to our own plan starting in January. And the employees who've had a sneak peek and used it so far have had raving reviews.
2 skeptics. Too.
Even my daughter,
Yeah.
who would probably trust TikTok more than Doc, used it, and she enjoyed it. And she's 17, so there's hope.
I'm in our high deductible health plan, HSA qualified, and I've had probably 3 encounters that I've run through this model that haven't cost me a dime.
Right. 322.
Yeah, and so anyways, we talk about strategy later, but it's just to Chad's point about increases, about limited options for employees and employers. This type of a concept can ease some of the pain, which is maybe you have to move the deductible up. Maybe an employee has a choice between a high cost or a low cost plan, but if they choose the low cost plan, then they're out of pocket if they go see a doctor. But if you have access to virtual direct primary care, that helps ease that pain of, what if I need to go see a doctor? Just take this route. And you can have that conversation. Now, to be clear, the prescriptions that are written and the imaging potentially that's ordered, that does run through the health plan. I just want to make sure that the audience understands that little tiny nuance.
Right. Well, thank you all. I think direct primary care is something that is definitely here to stay, and we're just going to see the models continue to evolve because this is a gap in our system that I don't think is going to be fixed anytime soon in terms of a flood of primary care physicians coming into our system and solving the individual access issue anytime soon. And so I'm excited for our own experience as an employer and what that allows us to offer to our clients. Because you can add this at any time. You don't have to wait until your renewal. And so this is something that could be added in February, March, April, May. And so for any employer who's looking to solve this problem and not wait until your next renewal, you don't have to wait.
They just need to call us.
Yep.
All right, and just to be clear.
Yeah. There we go. Well, with that,
Yes.
Thanks again for joining us for the TPG Difference. And thank you to my panel. Lily, welcome. It was so nice to have you today.
It was wonderful to be here.
Yes, you're awesome.
The information in this video is for general informational purposes only and should not be considered legal, financial, insurance, or HR advice. Viewers should consult with a qualified attorney, insurance professional, or HR expert for guidance specific to their situation. The views expressed are those of the speakers and do not necessarily reflect those of their employers or affiliated organizations.